In chapter 12, we'll be talking about chemical disasters and how they affect public health, specifically using an incident that occurred back in the 80s in Bhopal, India. Chemical disasters, similar to biological agents, bioterrorism, fall into two main categories. Deliberate releases, such as mustard gas or sarin, and unintentional industrial releases from factories or plants. Modern industries rely heavily on chemicals for everyday products, but this large scale infrastructure also carries risk. When hazardous substances are accidentally released, the consequences can include immediate casualties and long term health effects, as well as environmental damage. A powerful example of this happened back in 1984 in Bhopal, India, when 45 tons of methyl isocyanate gas was released from a pesticide plant, exposing about 500,000 people and causing thousands of deaths and injuries. Bhopal underscores the critical role of public health preparedness, chemical plant hazard awareness, and strong post disaster response systems. A little bit of history here. Since the Industrial Revolution, large scale chemical production has become embedded in modern life. But as production scales up, so does the risk of environmental and public health disasters. We've seen this repeatedly in events like Minamata's mercury poisoning, the Seveso dioxin release, and the Love Canal. Chemical industries are transnational and their impacts are global. Production often shifts burdens onto developing countries where worker and community protections may be weaker. Profit motives can conflict with public health priorities. For example, uh, Carbaryl, marketed as a safer pesticide, was widely promoted and produced globally. The demand for pesticides and the outsourcing of toxic production created conditions that ultimately contributed to disasters like Bhopal, highlighting the need for global public health accountability. Several years after the Bhopal disaster, Union Carbide financed a 500-bed hospital in 1991 to provide long-term care for survivors. The Bhopal Hospital Trust was established in 1992, and the Bhopal Memorial Hospital and Research Center opened in 1998. Today, it has 17 departments and focuses on specialized care for gas victims. Clinical and epidemiological work, as well as training healthcare professionals, all happen at this center. Earlier in 1985, Union Carbide provided $5 million in relief funds to establish 4 community clinics in the affected areas. These clinics operated until 1995, and the remaining funds were transferred to the Bhopal Hospital Trust. After the Bhopal disaster, India's Ministry of Gas Relief established a research institute, and the Indian Council of Medical Research led long-term studies on the health effects of methyl isocyanate. Over a decade, ICMR conducted longitudinal cohort studies and published findings on the gas's impact, especially on the eyes, lungs, and nervous system, and even examined chromosomal damage and PTSD. These efforts created critical short and long-term health data and informed clinical manuals and care strategies. This work reflects the first essential public health service, assessing and monitoring population health. Long-term tracking not only builds evidence for care and policy, but also strengthens trust and collaboration between communities, researchers, and public health systems. The third essential public health service is about informing, educating, and empowering people. Bhopal reinforced that emergency preparedness isn't just about plans on paper, it requires well informed citizens and well trained responders grounded in a true never again mindset. At the plant, workers technically needed engineering degrees, but in reality, training was shortened and safety education was limited. Safety was often added at the end of the design process, focusing on controlling hazards rather than eliminating them. That created a compliance driven, minimal approach to risk. After Bhopal, there was a stronger push in India to prioritize risk awareness, process safety, and education for workers, responders, and government officials alike. The incident in Bhopal, India, significantly strengthened the regulatory framework there. The Ministry for Environment and Forests was established, the Environment Act was passed, and the Factories Act was amended to address hazardous processes. Additional rules, including chemical storage laws, public liability insurance requirements, and the emergency planning, preparedness, and response to chemical accidents rules, mandated emergency preparedness plans at both the district and factory level. At the same time, the disaster elevated human rights discussions, reinforcing that corporations are responsible for worker health and safety. This directly reflects the fifth essential public health service, which revolves around creating and implementing policies and laws that protect health and set clear expectations for industry and government alike. At the entry level, safety, risk management, and operational standards must reflect a strong public health ethic. While community engagement is critical, policy and strategic decisions about where hazardous facilities are located and whether communities can respond to large scale incidents are equally important. Balancing industrial development with public health protection remains a modern challenge. In 1985, just a year after Bhopal, a Union Carbide plant in West Virginia experienced a similar malfunction, releasing aldehyde carboxyme and sickening over 100 people. Though there were no deaths, it revealed that U.S. plants were not immune to similar risks. In response, Congress passed the 1986 Emergency Planning and Community Right to Know Act, expanding public access to information about hazardous chemicals and strengthening community preparedness. After Bhopal, the government of Madhya Pradesh established the Disaster Management Institute in 1987 to institutionalize the lessons learned. It developed executive refresher courses on managing chemical accidents and formal guidance on emergency preparedness, turning tragedy into structured public health competency. A key takeaway is that every large industrial complex requires a meaningful risk assessment. Stakeholders must ask themselves, what happens if this fails? Who is affected? How do we mitigate harm? Understanding what's at stake and for whom is central to protecting the public. This aligns with the second essential public health service, which is investigating and addressing health hazards. Post-Bhopal investigations revealed serious gaps between risk awareness and operational practice, reinforcing that hazard prevention must remain central to future planning and development. Crises are often described as low probability, high impact events, but when the impact is catastrophic, operating standards must change. The greater the risk, the stronger the public health response should be. Wider buffer zones, higher safety standards, and better community education. After the Bhopal incident, the scale of the tragedy transformed the labor environment in India. Advocacy for safer working conditions and stronger employment protections grew significantly, helping spark a broader public health movement. This connects directly to the eighth essential public health service, which is building and supporting a skilled public health workforce. A diverse, well trained workforce and a commitment to equitable working conditions are foundational to protecting both workers and communities. In the aftermath of the Bhopal incident, response efforts quickly expanded beyond the local level. Community groups and small NGOs or CBOs mobilized immediately, while international organizations, including WHO, the World Health Organization, representatives, had demonstrated global concern. The European Economic Community even sent large quantities of milk powder for affected children. Locally, NGOs, non governmental organizations, focused on direct survivor support, healthcare, clinical services, while international networks tackled broader issues like environmental accountability, human rights, education, trade, and corporate responsibility. All of this reflects the fourth essential public health service, which is strengthening and mobilizing community partnerships. Because Bhopal was transnational in impact and responsibility, meaningful recovery required collaboration across local, national, and global levels. Although another Bhopal scale disaster hasn't occurred, it's difficult to measure how much true progress has been made. Hazardous chemicals like methyl isocyanate and carbaryl are still in use. The absence of similar catastrophes may reflect improvements in safety and the integration of public health principles into industrial systems. Moving forward, open dialogue about between communities, public health officials, and industry leaders is essential. Residents living near industrial plants need accessible information about risks and protections. Public health competencies must be embedded at every level, from local leadership to transnational corporations. This reflects the 10th essential public health service, which is building and maintaining a strong public health infrastructure. Paul reminds us that lasting safety depends on systems that prioritize public health at their very core.